us. Best wishes for you, sir. May you start, sir?
Thank you, sir. Thank you very much. Shall I start my presentation?
Yes, please, sir.
Good evening, everybody. I would like to thank the office bearers of Benha course and the Egyptian Orthopaedics for the opportunity to talk. I bring greetings from India and wish you all a healthy life in these difficult times. I'm going to talk on biomechanics of the knee. It's actually a big subject. I believe biomechanics related to arthroplasty has been discussed before. And I'll try to focus on biomechanical principles and concepts related to ligaments of the knee. I have nothing to disclose and I don't gain anything monetarily with the topics related to my talk. I'm a consultant orthopedic surgeon at Vijayawada in Andhra Pradesh in India. This is the overview of my talk. I will talk on basic biomechanics, knee biomechanics, articular cartilage, meniscus, and ligament biomechanics. We'll go a little into details of ACL biomechanics. Looking at the basic biomechanics, biomechanics is a study of the mechanics of the human body in relation to its surroundings and its integrity with respect to the forces acting on it. The branches are statics and dynamics. Statics deals with relationships between objects that are at rest or moving with a constant velocity. Dynamics deals with bodies that are undergoing a change in their velocity. Dynamics has two subsections. These are kinetics and kinematics. Kinetics is a study of forces that cause motion of a rigid body, and kinematics is a study of motion without regard to forces that cause motion. So you must be knowing stress-strain curve. It's one of the most important graphs in biomechanics. I'm not going to the details of this because that becomes a basic biomechanics talk. The properties of a material that do not depend on stress-strain curve are two. These are creep and stress relaxation. Creep is an increase in strain under constant stress, and stress relaxation is a decrease in stress under constant strain. And viscoelasticity is a time-dependent property of a material wherein a low strain, at low strain rates, the material is ductile, and at high strain rates, the material is brittle. Articular cartilage lines the articulating surfaces of the natural joints. Macroscopically, it does not have a perichondrium. It is avascular, alymphatic, and aneural. And microscopically, water is a major component. It has hyaline cartilage, and its matrix contains mainly collagen type 2. It has a toe region in the stress-strain curve, and even ligaments and tendons, like all biological materials which have collagen, have a toe region because of the crimping and wavy nature of the collagen contained within it. It has a biphasic poroviscoelastic behavior for compression, which means it has a fluid-dependent as well as a fluid-independent component of supporting loads. Anisotropy means it has different behavior with different direction application of forces, and it is inhomogeneous for tensile forces. Lubrication is another important property. We'll go into it shortly. It is lubricated by synovial joint. The primary function of articular cartilage is load support and movement. Frictional drag of the interstitial fluid and fluid pressurizations are mechanisms by which it supports the load. And the arrangement of cells and collagen in articular cartilage gives a clue to the types of loads that act on the articular cartilage. As you can see here, the superficial the cartilage, flat cells, the superficial layer. As you go down deeper, the cells are more cuboidal. Similarly, the collagen fibers are organized parallel to the surface on the superficial surface, and as you go deep, they are perpendicular to the subchondral bone. So this indicates at the superficial layers, the forces are mainly acting tangentially, whereas as we go deeper, the forces are acting more perpendicular to the subchondral bone. Coming to viscosity, it relates to fluids and shear stress to shear strain in a fluid. It does not have much relation to modulus, but viscoelasticity, as we have seen, is related to stress, strain, as well as modulus. For Newtonian fluids, viscosity is constant with shear strain and stress. The examples of this are water and oil. And for non-Newtonian fluids, with increasing shear strain rate, viscosity either decreases, which is called thixotropic, and synovial fluid is thixotropic, or increases, and these are called dilatant fluids. Example of that is sand and water. Mucopolysaccharides contribute to viscosity in synovial fluid. Lubrication in the joint does not occur by a single lubrication mode, but by a synergistic combination of different modes. And I have listed a few modes of lubrication here. The common ones are fluid film lubrication, also called hydrodynamic lubrication. The mechanisms are squeeze film, which happens in the stance phase, and entraining, which happens in the swing phase. And elastohydrodynamic lubrication is another type. Boundary and fluid film can happen. If you can see the graph here, it's called a Strybeck curve, and we have represented a lambda ratio here. Lambda ratio is film thickness by roughness. So if this ratio is less than 3, boundary lubrication occurs. This is basically lubrication between two smooth surfaces rubbing against each other with little fluid. And if the lambda ratio is more than 3, fluid film lubrication occurs. Boosted lubrication happens because of trapped pooled synovial fluid in the cartilage, making leaking of synovial fluid difficult, leading to better lubrication. Biphasic is basically 2 types of lubrication occurring: fluid film ahead in the front and imbibing behind or at the trailing end. So moving on to knee biomechanics. Sorry. So we all know that knee joint is a ginglymus and a diarthrodial joint. There are 3 independent articulations and 6 degrees of freedom with 3 translations: AP, mediolateral, and compression distraction, and 3 rotations: flexion, extension, varus valgus, internal, external rotations. Range of movements are 0 to 15 degrees and 130 to 150 degrees of flexion. The stability of the knee is due to static and dynamic restraints of the knee joint. The stability is predominantly ligamentous in the knee, and we know the list of ligaments responsible for stability, which are ACL, PCL, MCL, LCL, posterolateral corner, posteromedial corner, and the menisci. Dynamic stability is because of the muscles, and these are hamstrings, quadriceps, iliotibial band, and the popliteus. Looking at the bony architecture, the medial compartment has better articular congruence. Center of rotation remains stationary. The articulation is convex on concave, and there's fixed medial meniscus. It doesn't have much mobility, and medial femoral condyle is larger, more posterior, and more distal. Medial tibial plateau is concave and larger. On the lateral side, the opposing bones are less congruent, convex on convex. The mobility of lateral meniscus is more than the medial meniscus. Lateral femoral condyle is smaller, variable, with a variable center of rotation, and prominent anteriorly. Lateral tibial plateau is smaller and convex. The screw home mechanism occurs in the knee, and there are differences in radii of femoral condyles. The posterior condyles are equal. Lateral condyle is longer and flatter than the medial side, and differences in the tibial topography from side to side is different. The lateral facet is saddle-shaped and generally convex. And due to this asymmetry, the tibia is obligated to externally rotate in extension. So it can be an open chain where the tibia rotates, or in a closed chain exercise, the femur rotates on the tibia. So the medial tibia basically rolls farther forward than the lateral side in extension. We also know there is a femoral rollback, and I think this may have been covered under arthroplasty section, so I'm not going into the details of this. Similarly, mechanical access is very important. This may have been covered in the arthroplasty section as well. So I'm not going into details of this, but it is important in sports injuries because ligament reconstruction should not be done in a malaligned knee. It should be done on a physiologically aligned knee. If reconstruction is done on malaligned knee, it fails. The ACL and PCL, as well as even meniscal repairs may fail. It is important to note that progressive osteoarthritis occurs in a malaligned knee, and it's faster than in a physiological aligned knee. It's faster in a varus knee compared to a valgus knee. So the vastus medialis obliquus acts at an angle of about 65 degrees with the axis of the patella and the quadriceps mechanism. And that is why it has a significant effect on the tracking of the patella as well as on treatment of maltracking of the patella. Coming into the patellofemoral biomechanics, the variables of patella include position. It can be either superior, which is called patella alta, or patella baja if it's inferior. It can be medial or lateral. The patella can be rotated internally or externally. The size can be large, patella magna, or hypoplastic patella. There can be aplasia, or it can be excised. The width of the patella may be increased, or the thickness of the patella may be increased. All these can have an effect on the patellofemoral joint mechanics. So what are the supports of the patella to assist the stability? Joint geometry is important to some extent. Medial and lateral facets of the patella articulating with the sulcus of the trochlea and ligaments of perhaps the relative instability of the lateral compartment that is there cause the lateral trochlear facet to be more prominent to stabilize the patella. The static and dynamic soft tissue supports include medial patellofemoral ligament, which gives 60% of stability at 20 degrees of knee flexion, and secondary restraints include meniscopatellar ligament and medial retinaculum. And understanding PFJ instability is evolving with more ligaments being discovered. Other restraints include in the proximal group, medial quadriceps tendon femoral ligament, MPFL we have seen, medial patellotibial ligament and medial patellomeniscal ligament. The role of these ligaments in stability is still to be established. Dynamic forces include quadriceps and vastus medialis obliquus. Tracking depends on the active contraction of the quadriceps, the extensibility of the connective tissue about the patella, the geometry of the patella and trochlear groove, and movements of patella include gliding, tilting, and rotating. So patellofemoral joint reaction force is dependent on knee joint angle and muscle tension. When the foot is fixed, the reaction force increases from 90 to 45 degrees, then decreases as the knee approaches full extension. The reaction force and the patellofemoral joint stress can be very high in activities of daily living, not to mention with sports and recreational activities. So for level walking, the joint load is half the body weight. It progressively increases in cycling, going upstairs, downstairs, running, squatting, up to a maximum of 20 times body weight for jumping. If we study the contact areas, the figure shows how the contact area between the joint surfaces moves in trochlea and patella as the knee is flexed from 0 to 120 degrees of flexion. More area of contact is seen on the lateral femoral condyle and becomes two-pointed in full flexion. On the patella, it starts from the inferior pole, and this is at 30 degrees of flexion, and reaches superior pole at full flexion. If we look at the patella tracking, normal tracking happens along the trochlear groove. In maltracking, once the superior part of trochlea is reached, during active extension, patella moves laterally, creating an inverted J-shaped track. Maltracking can also be seen in mediolateral directions or superior-inferior directions. Moving on to meniscus, the functions of meniscus are to increase congruency of the joint, distribute the loads, load bearing, shock absorption, load transmission, lubrication, nutrition of the articular cartilage. The whole of the meniscus is vascularized at birth, and the inner 1/3 loses its vascularity as we start weight bearing. Meniscus has been divided into 3 zones: red-red, red-white, and white-white. 72% of it is water and 28% extracellular matrix. The matrix contains mainly type 1 collagen in red-red zone and type 2 in white-white zone. The glycosaminoglycans are 17%, and the majority of it is made up by chondroitin sulfate. Medial meniscus is C-shaped. I will not go into the anatomical details, but just the biomechanical aspects of these. It is wedge-shaped in cross-section with the given dimensions there, and it covers about 50 to 70% of the medial articular surface. The lateral meniscus is semilunar and again wedge-shaped with the dimensions given there. It is supported by the meniscofemoral ligaments, and it covers about 75 to 90% of the lateral articular surface, and it's more mobile than the medial meniscus. As the femur loads the meniscus, because it is fixed at the anterior and posterior horns, it is pushed outwards. If you look at the figure here, the resultant pushes the meniscus outwards, as seen in the resultant figure. And these stresses radiate outwards from the meniscus. These are called hoop stresses. Meniscus is stronger circumferentially by 10 times compared to radially. So a bucket handle reduced can be easily by a suture than a radial tear. So a radial tear requires more robust repair and fixation, stronger than a bucket handle tear. Both the menisci move during range of movement of the knee. The lateral meniscus moves more than the medial meniscus. This was given by the study by Vedi et al. The menisci occupy about 60% of the contact area and transmit more than 50% of the total axial load. The contact area decreases with flexion by 4% for every 30 degrees of flexion. At full flexion, lateral meniscus transmits about 100% load, while medial meniscus 50%. Partial meniscectomy causes more than 350% increase in contact forces, and total meniscectomy decreases contact by 50%. And partial meniscectomy again is cartilage degeneration, and 3 to 7 times risk of osteoarthritis later is increased. There is inflammatory cytokine release, which worsen osteoarthritis. Quadriceps weakness happens, and in athletes, 60 to 90% develop osteoarthritis in 5 years. There is altered gait, which leads to increased load on the anteromedial side, and the effects are worse in patients with malalignment. 25 to 50% lower risk of consultation for osteoarthritis is seen for repaired meniscus compared versus partial meniscectomy. Total meniscectomy increases osteoarthritis by 14 times at 20 years, and if there is significant varus, they can also develop significant varus and osteoarthritis at 40 years. Coming on to ligament biomechanics, there are two types of ligaments: vascular, which are covered by paratenon, and avascular, which are covered by a synovial sheath. Microscopically, they have a ground substance made up of collagen type 1, fibroblasts, and water, 80%. And biomechanical properties, again, they have a stress strain curve with a toe region. And factors affecting biomechanical properties include aging, pregnancy, mobilization, diabetes, steroids, NSAIDs, hemodialysis. And biomechanical behavior includes viscoelasticity, we have discussed before. It is stiffer at higher strain rates. So they fail at lower loads in slow loading pattern compared to a faster loading pattern. Coming on to ACL biomechanics, we'll go slightly into detail in ACL. These are the headings I'm going to discuss ACL. Structurally and biomechanically, we have known ACL has two bundles. This is called the bundle concept. It's more popular than the ribbon concept. So we'll just look at the bundle concept. Ideal concept I'll come into later. The functions of ACL are to prevent tibial translation anteriorly. In full extension, all fibers are under tension. It rotates 180 degrees when over 90 degrees of flexion, and fibers are not isometric. The attachments are 3 times the cross section of the mid ACL. So there are two bundles, namely the anteromedial and the posterolateral, based on the insertion of the location of the tibia. The AM bundle is behind and PL bundle is in front of the lateral bifurcate ridge on the femoral side, and both of them are distal to the lateral intercondylar ridge, which is called the resident ridge. As the graph shows, distance between bundles increases with increasing flexion. AM bundle is tight in flexion and important in anterior draw, and PL bundle is tight in extension and is important for Lachman. As the flexion of the knee increases, the in situ force generated generally decrease in both bundles as seen in this graph. Tension is maximum at 20 degrees of flexion. This is the position at which we fix the graft during ACL reconstruction. A quick look into the kinematics during gait. During gait, both bundles are anisometric and maximally elongated throughout mid-stance of the gait. At full stance, they are fully elongated. So in situ forces are up to 170 newtons normal walking, 445 newtons while descending stairs. ALL or anterolateral ligament is gaining importance of late. I will skip the anatomy again. It originates from proximal and posterior to the lateral epicondyle and inserts between the Gerdy's tubercle and fibular head on the proximal tibia. So it is found in around 83% of the knees. It increases in length on internal rotation of the knee at 90 degrees of flexion, an important pivot shift. So it is isometric from 0 to 60 degrees flexion and slack on further flexion. The indication for ALL reconstruction usually are an explosive pivot shift or a high-grade pivot, demanding athletes, chronic ACL insufficiency, or revision cases. The biomechanics, some biomechanics of ACL injury, these are the risk factors for ACL injury. Anterior translation and valgus factors in general, and joint morphology and joint laxity can cause ACL injury. In general morphology, pelvic tilt, femoral anteversion, and subtalar pronation are important. In joint morphology, tibial slope, notch width, and ligament tibial condyle geometry play an important role. This shows the force vectors around the knee. Quadriceps is ACL disruptive, so and protects the PCL. Hamstrings is ACL protective since it prevents anterior translation of the tibia. ACL occurs so fast it is not possible stop injury. Females have the following predisposing factors for injuring the ACL. They have small notch width, knee valgus, joint laxity, and altered neuromuscular properties. So what does ACL deficiency lead to? Disrupts roll glide mechanism. It increases anterior translation of the tibia, increases internal rotation of the tibia, and loading on secondary restraints like medial meniscus gets loaded if ACL is absent. Osteoarthritic changes are seen in 60 to 90% of cases after 10 to 15 years. In acute injuries, lateral meniscus is commonly injured, and in chronic injuries, medial meniscus lesions are more common. And 80% of cases may have medial or lateral meniscus lesions. So this shows contact points for ACL deficient knee. The stars indicate contact points from extension to flexion. Blue stars indicate contact points in intact knee. Red stars in an ACL deficient knee. Shaded areas indicate loading of the knee. The green shade indicates pivot shift, which is over the posterior horn of the lateral meniscus, and violet shade indicates loading on ligaments, which is over the posterior horn of the medial meniscus. The medial pressures decrease and the lateral pressures increase, especially around flexion angle of about 60 degrees. So now biomechanics of ACL reconstruction. Most of the grafts are stronger than the native ACL, as you can see from the ultimate tensile stresses in this table. Preference to each is given in different situations. The indication is highlighted here for each graft. BTB is preferred more in high demand athletes, 4-strand in low demand patients, quadriceps and revision surgery. And the variables related to graft are graft diameter, more than 8 millimeter is preferred, source of graft, the material and the strength of graft should be taken into consideration, and graft tension is also important. Hopefully all these will be covered under ACL reconstruction. Fixation is very important as it holds the graft until the body heals it and takes over. Ideal fixation should be strong, stiff, secure, anatomic, reproducible, biocompatible, easy for revision, and MRI compatible. The different types of fixation are aperture fixation and suspensory fixation. Aperture is using interference screws. Suspensory can be cortical or cancellous. Cortical is endobutton or tightrope. Cancellous is the example is transfix. Screw and post and staples may also be used to fix, and hybrid fixation is the other category. Bungee effect and windscreen wiper effects are important biomechanical concepts that should be kept in mind. Bungee is elongation of the graft, whereas windscreen wiper is side-to-side movement of the graft. Now ACL reconstruction biomechanics. So there should be 6 millimeter space between anterior part of the tunnel and contact point of notch. Center of tunnel should be around 15 millimeters anterior to the PCL, and recommended angle is about 40 to 50 degrees fixation. And femoral tunnel is found to be the most sensitive for the kinematics of the knee. For a single bundle reconstruction, tunnel is placed in the center of the whole footprint. In double bundle reconstruction, tunnels are placed in center of each bundles. So these are reference points for the tunnel placement. Different strategies can be used to identify the point of tunnel placement. So IDEAL is an acronym. Over 25 years of publications were researched through to find the right point for tunnel placement. And position of tunnel should be I for isometry of native ACL, D at the site of direct fibers, and E for eccentrically located, which is anterior, high, and deep or proximal part of the footprint. A for anatomic location within the footprint, and L for low tension stress pattern of the native ACL. What happens when tunnel is malpositioned? On the femoral side, 2 anterior graft tightens in flexion, 2 posterior graft slackens in flexion. On the tibial side, if it is placed 2 anterior, it tightens in flexion and impinges in extension. If it is 2 posterior, it tightens in extension and impinges on the PCL. To summarize, ACL is an important restraint for anterior translation and internal rotation. Biomechanics are evolving from bundle to ribbon. ALL is an important role for pivot shift, and deficiency exposes the secondary restraints to injury, and most current grafts have good biomechanical properties. Tunnel position is critical for success and prevents complication. There's limited role for double bundle reconstruction. Coming onto the lateral side biomechanics, there are 28 unique static dynamic stabilizers. The most important ones are fibula collateral ligament, popliteofibular ligament, and the popliteal tendon. Poor healing occurs due to inherent instability on the lateral side because of the lack of conformity between the convex lateral femoral condyle and the convex tibial plateau, coupled with higher mobility of the lateral meniscus. Also, the normal mechanical axis of the main population crosses the knee slightly medial to the neutral axis of the knee, and during an adductor movement, the axis becomes even more medial. Integrity of the posterolateral corner is of paramount importance to avoid opening of the lateral side. So increased muscle activity to protect against the varus opening can actually increase the joint loads and increase the peak stresses in the joint. During the stance phase, the medial compartment is under compression, while the lateral structures are under tension, secondary to the relative position of the mechanical axis of the lower extremity. So popliteus tendon is the window to the posterolateral corner. As the tendon passes through the popliteal hiatus, it is anchored to the lateral meniscus by 3 fascicles. The lateral structures of the knee function as primary stabilizers against varus gapping, external rotation, and coupled posterolateral tibial translation. They also have an important role in stabilizing internal rotation. Chronic lateral instability strains the cruciates, ACL and PCL, and leads to failure of grafts if they were reconstructed. Lateral compartment gapping of 4 millimeters or more on varus side at 20 degrees of flexion is indicative of PLC injury. Popliteus tendon is a primary restraint for external rotation, secondary restraint for internal rotation. Fibula collateral ligament is primary restraint for varus and secondary for anterior translation and internal rotation. And these ligaments individually are weaker than ACL. So all these 3 need to be reconstructed to provide support to these forces. Dial test is done at 30 degrees of flexion. If it is positive, indicates a posterolateral corner injury. If it is positive at 30 and 90 degrees, it indicates PLC and PCL injury. You can see in this figure, the PLC intact and the PCL intact. So as we do a dial test, it centers around the PCL and external rotation is increased. And if the PCL is also injured, there is increased, even more increased external rotation. So the main structures on the medial side that are surgically important are superficial MCL, deep MCL, and posterior oblique ligament. Superficial MCL is the primary restraint for valgus and secondary restraint for external rotation. Deep MCL is primary restraint for internal rotation and secondary for external rotation. It has two components, the meniscotibial and meniscofemoral portions. Femoral part serves as primary restraint for internal rotation, and the posterior oblique ligament is primary restraint for internal rotation, and it complements superficial MCL in internal rotation restraint, and it is reconstructed at 0 degrees of flexion, while superficial MCL is reconstructed at 30 degrees of flexion. Femoral insertion site gets maximum strain and the most common site of failure, while the posterior oblique and deep MCL fail interstitially. Ultimate strength of the MCL is the same as ACL. So this shows the anteromedial rotatory instability. Isolated injury to the MCL causes increased gapping on the medial side on valgus stress. If posteromedial corner is injured, along with ACL injury, it increases the external rotation. So it can also be, the test can also be done with an anterior drawer and an externally rotated knee. If it opens up in full extension, if on valgus strain, if it opens up in full extension, posterior oblique ligament is injured, and if it opens up at 30 degrees of flexion, the MCL is injured. So anteromedial rotatory instability occurs with ACL and MCL injury. Anterior draw will be increased in neutral as well as internal rotation in presence of ACL and MCL injury. So I think it's the other way around. Posterior draw will be increased in neutral as well as internal rotation in the presence of PCL and MCL injury. Whereas in isolated ACL and PCL injuries, the draw test decreases after external rotation and internal rotation respectively with intact MCL. So PCL, posterior cruciate ligament, causes posterior restraint in all degrees of flexion. It is a primary restraint at more than 90 degrees of flexion for internal rotation, and secondary restraint for external rotation at more than 90 degrees of flexion. It has two bundles, anterolateral and posteromedial. Both bundles act synergistically and codominantly. Previously, their behavior was similar to ACL bundles, but now their action is thought to be synergistic and codominant. AL bundle causes posterior tibial translation restraint from 70 to 105 degrees, and PM bundle restraint at 0 to 15 degrees. If both of them are cut, the posterior translation of more than 11 millimeters occurs. Posteromedial bundle is the most important bundle to control rotation more than 90 degrees of flexion. So to summarize, stability of the knee joint depends on ligaments and bone geometry in the knee. It is important to know the biomechanics of these ligaments are important to study to get better results with the reconstructions. Complex biomechanics in multi-ligament injuries and specific biomechanics should be dealt probably in appropriate sections in your other talks. Thank you very much.
Thank you so much, Dr. Srinivas, for this interesting and illustrative talk. Now we have the question time. If anyone of our audience and attendees has a question to Dr. Srinivas.
should I stop sharing my?
Yes, sir. Any question from our audience? I think, sir, you made everything quite obvious. So we have no questions from any of our audience. It's all clear, sir. It was a great pleasure to meet you. Oh, yeah, we have a question now. Oh, yeah, they are saying that it's a very nice talk full of information and very informative session, sir. Thank you so much. Thank you so much.
Thank you very much for inviting me again.
Thank you. Best wishes for you and all the Indian people.
Thank you, sir. Thank you.
Hoping to see you in Egypt very soon.
Sure. Thank you for
Thank you so much. Thank you so much.
Thank you very much.
Thank you, sir.